Hello, everyone. A very good afternoon. I'm Dr. Bhumika Sharma, and I'm an educator for ophthalmology. So, we are meeting just one day before the Valentine's Day, and the countdown has started for NEET PG 2023, right? So, right now, your Valentine should be your books, your notes, the quick notes that you have made, your PDFs. So, it's an advice from me, do not start anything new. All right. Hello, Kaushal. Hello, everybody. Hello, Shreya. If everything is good, if the voice is fine, the video is fine, please give me a thumbs up and just reassure everything is going well. So, yes, coming back to the point that right now, my advice to you is do not start anything new. It is overwhelming, it is panicky, it is something which will make you feel not very good at this point of time. The sole purpose right now is revise, revise, revise. The thing that makes you come over others is actually your time saving and your quick response, and obviously the knowledge. So, what I want from you is that you should be revising so much that the moment you read the question, you have the answer right here. You don't have to think about a second choice. You don't have to read the options. Because if you don't have to read the options, that would save onto your time and that would save onto your mental energy. And that is my target for my students. So anything and everything that I teach, I do not give options because I want the training to be to a level that once you read the question, you know the answer. And that's how it's going to be. So today's class basically, hello everyone, hello. So today's class is basically my aim is to cover as many images as possible. I will be covering their detailed discussion later on the platform. That would be on 25th and 27th. That is 2 to 4. That would be a concept revision. That would be a quick revision of all the one-liners and all. And today I will try to cover all as many images in this 1 hour as possible with, yes, covering those one-liners, those quick answers that you should know, and the important anticipated and the previously asked questions, right? If everything is okay, if no doubts, let's get started. So the first image that I have, as I told you, I will not be giving you options. These are not the options. These are just the part of the questions. So I want you to be trained to a level that you read the question and you tell me the answer. Because try and understand, the options are made to confuse you, to get to waste time, right? So if you start reading the options, maybe few seconds that you lose, and then the mental exhaustion that comes with it is actually going to count on you. So I know, believe in yourself, keep revising, and just aim for one thing, that the moment you finish the question, you don't have to read the options. And that would be my target for this session also, right? So let's get started. Absolutely, this is endothelium, but this is not what I'm asking you. I mean to ask is, what is this test? So you have to identify what you are seeing as endothelium. Absolutely, it's not spectral microscopy. It is, what is this test and what is that you can see? So the thing that you can see here is basically a mosaic pattern of hexagonal cells. And what is this? This is specular microscopy. This is specular microscopy. Which test is this? It's not spectral, it is specular microscopy. So what is specular microscopy? It is basically a process to understand the size, to study in detail the size, the shape, and the distribution of endothelium. So it studies the size, the shape, and the distribution of the endothelium, right? So this is specular microscopy. This is specular microscopy. All right. And now quickly coming to this, you should remember endothelium is a monolayer. It is a monolayer. It is a mosaic pattern of hexagonal cells. And here what you see, if you see carefully, what you get to see here is basically these cells which are lying, and there are these dots in the center. This is the nuclei. So what is the distribution here? I've told you there is a monolayer, they have hexagonal shape, and what is the distribution? So what is the cell density? So when we talk of density of the endothelium cells, this is something which is important in the periphery. What is the cell count in the periphery? It is not this how you write, it is 8,000 cells per millimeter cube. This is the normal cell count in the periphery. In the center, when we talk, the cell count is 3,000 cells per millimeter cube. And important thing is the endothelium decreases at the rate of, okay, I was about to ask you, I wrote it, decreases at the rate of, please write it down, 0.6% per year is the decrease that we get to see. Important, under what cell count is the endothelium or is the cornea predisposed to have corneal edema? Tell me, under what is the cell count under which you will have corneal edema? The cell count below which you will have corneal edema. This is very, very important. Corneal edema. Predisposed to have corneal edema. When the cell count goes less than, absolutely urgent. Very good. That is when it is 500 cells per millimeter cube. So once the cell count is less than 500 cells per millimeter cube, the cornea is bound to go into corneal edema and further decompensation. Very nice. So these are the things that you should remember, right? The shape of the endothelium and the cell count. And what is the decrease? It is 0.6% per year. And corneal edema. All right, the second thing that I need to know about this is, what do you get in this? This is again specular microscopy, absolutely what I said. But what is the difference between this image and the subsequent image? Any changes that you can see? See, specular is a little hazy. I agree the image would be a little hazy, but I suppose rest of the is coming well, right? So here, this is a normal specular microscopy. Remember, when we talk of endothelial cells, a very important property that they have is they have limited proliferation in vivo. But this proliferation is not an issue in cell culture medium, right? So when we talk of a limited proliferation in vivo, so when you have a cell damage, what you land up into? You land up into polymorphism and polymegathism. And that is what is shown in this image. That is what I'm trying to show you here. If you see these cells, these are large cells. Just compare, these are hazy, these are large cells. And if you compare them to the previous slide, that means morphism means, when I talk of morph, it means shape, it means form. So polymorphism is when there is variation in the shape of the cells, and polymegathism is when there is variation in the size. So size is basically polymegathism and shape is what you call is polymorphism. So this is how you see the specular microscopy. All right. Okay, next image. Identify these two. This is easy, I know. Come on, identify. What are you seeing here, and what is the point of consideration? Is it lens or is it something else? So you see, this is the normal contour of the cornea. I still not got any answers, and this is what, let's concentrate on this image first, and this is the contour of the cornea that I am asking you. So let's talk of image A first, and this is image B. Talking of image A first, what is the diagnosis? Image A, absolutely, it is keratoconus. So this is keratoconus. What is keratoconus? It is a cone-shaped cornea. It is a cone-shaped cornea. Vis-a-vis what you get here is a globular-shaped cornea. And what is this called? This is called as keratoglobus. Perfect. So this is keratoconus and keratoglobus. Now quickly answer me 2-3 questions. What is the earliest sign seen in keratoconus? Quickly tell me. My question is, what is the earliest sign? I should keep getting the answers quickly. The earliest sign you have to tell me, and you have to tell me what is the refractive error that we get to see in keratoconus. Third point that you have to tell me, what is the investigation of choice? 3 things that we're going to discuss about keratoconus is Munson's sign. No, it's not the Munson's sign. What is the earliest sign? Come on. So the earliest sign is, any more answers that you want to try? Anyone who wants to try? Okay, I'll tell you. The earliest sign is scissoring or yawning of red reflex on retinoscopy. On retinoscopy. So this is the earliest sign that you get. The earliest sign that you get is scissoring or a yawning of red reflex on retinoscopy. That is for keratoconus, what we are discussing. Okay. The other thing that I'm talking to you about, refractive error, is one is myopia and the other, you have to tell me, it is astigmatism. But tell me, what kind of astigmatism? Is it regular astigmatism or is it irregular astigmatism? Come on, quickly answer. Yes, absolutely. Shalini, very good. It is irregular astigmatism. I will highlight this further. This has been asked. It is irregular astigmatism. All right. So the earliest sign, scissoring or yawning of the red reflex. What is the most common refractive error that you get to see is myopia, or it is irregular astigmatism. And what is the investigation of choice? Very good, Saint. Very good, Sakib. Very nice. And what is the investigation of choice? Come on, what is the investigation of choice? The investigation of choice would be, if I give you the options of corneal topography and pentacam, number them as 1 and 2. So the first option would be absolutely right, Arjun. The first option is pentacam. So the investigation of choice is pentacam. But many a times there might be an option saying just corneal topography. So corneal topography, yes, it is a very sensitive method to detect the early keratoconus. But if pentacam is in the option, the answer would be pentacam. If pentacam is not given, if it is given obscan, it is given corneal topography, then the answer would be corneal topography. All right. So obscan, pentacam, corneal topography. This is how it is going to be. So the pentacam is the investigation of choice. All these follow corneal topography or corneal tomography. Right. So this is how it is. The investigation of choice, clear cut, pentacam. If it is not given, you might have corneal topography in the option. You might have obscan in the option, which would then be the answer. All right. Okay, then we come to keratoglobus. Keratoglobus, one very important point that you should remember here is, tell me, when do you get to see keratoglobus? Is it present at birth or it develops later? Tell me. Keratoglobus is, what you have to tell me here is, it is present at birth or later? Good. It is present at birth, and there is thinning and a globular shape of the cornea. There is thinning and the globular shape of the cornea. So this is keratoconus and keratoglobus. Come on, next image. All right, identify this. Identify this. What is this? Here I have given the options. I mean something to give you the options. You have to identify without reading the options, and then we'll discuss about the options. Tell me, what do you get to see here? My question to you is, what do you get to see? What is this? All right, you can leave this part first. You tell me this. Tell me, what is this? B, dendrites. Super. All of you have said dendrites. This is dendritic ulcer. And here, if you tend to see, this part is showing you a geographical ulcer. I've just tried to combine all these into this. Now, let's discuss what I'm going to ask you next. The important thing here is this is a dendritic ulcer. Where do you get to see a dendritic ulcer? Which viral infection? Come on. What is this? Which viral infection do you get to see this? Herpetic eye disease, herpes simplex. Absolutely. So now you have to tell me, if the answer is dendrites, why not it is pseudodendrites? Why not it is pseudodendrites? What is the difference between dendrite and pseudodendrites? Come on, quickly. What is the difference between dendrite and pseudodendrite? So basically, when we talk of dendrites, these are central corneal ulcers with terminal bulbs. Very good. You've got them right. Very nice. I'm so happy to hear this. Right. So these dendritic ulcers are basically central corneal ulcers. They are central ulcerations with terminal bulbs. Whereas when you talk of pseudodendrites, these are smaller in comparison to dendrites. They are peripheral and they lack terminal bulbs. All right. So you should know what is the difference between dendritic and pseudodendritic ulcer. And where do you get to see pseudodendrites? Which disease do you get to see pseudodendrites? Tell me. Where do you get to see pseudodendrites? I'm waiting for the answer. Very nice, Arjun. That is herpes zoster. Perfect. So this is where you get to see the pseudodendrites. So now we are left with two options, metaherpetic ulcer and geographical ulcer. Now what are these? So basically what happens is when there is either a long-standing ulcer or you give steroids to the dendritic ulcer patient, right? Or in immunocompromised status, the dendrites, they tend to coalesce together. So what are these conditions? When the dendrites, they convert to geographical ulcer. So what are the conditions? On use of steroids, immunocompromised status, or long-standing ulcers is what leads to from dendritic ulcer to a geographical ulcer. That leads to a geographical ulcer. If you want to see it clearly, you can see this. You can see the image. This here is basically a geographical ulcer. Right? I will show you in the subsequent image. Right? So this is when the dendrites, they coalesce together to form the geographical ulcers. So now when we come to this image, which is a geographical ulcer and which image is a metaherpetic ulcer? For you, I will make it a little easy. I will draw a line here. So these two images are same and these two images are actually same. So this is A and this is B. Tell me which is a geographical ulcer. Tell me. Rose Bengal. All right. So now I will tell you when the dendritic ulcers they coalesce together in the above mentioned conditions, they form a geographical ulcer. They form a geographical ulcer. And when do you get to go to the metaherpetic ulcer? When you have a defect in the healing process. When you have defect in the healing process, these are chronic epithelial defects with the heaped up epithelium. With heaped up epithelium at the edges. At the edges. All right. So now I need to ask you, what is the staining pattern? Absolutely right. I'm very happy, Dr. Kunal, Sadav Sheikh, and Barfi and Friends. Oh, that's a nice name to say. So this is the geographic ulcer. Now, quickly tell me, what is the staining pattern? The staining pattern that we get to see is the bed. As you can see in this image, the bed stains with fluorescein. Sorry. The bed stains with fluorescein and the edges stain with rose bengal. Right? And the edges stain with rose bengal. Whereas it is reverse in metaherpetic ulcer. That is why we say it as, we call it as a reverse staining pattern. Reverse staining pattern, where the bed is stained with rose bengal and the edges are lined by fluorescein dye. Now you need to understand, one way to remember from this, what you can remember is that the rose bengal stains the devitalized epithelium. Hence, it is reverse staining in the metaherpetic ulcer. I told you there's a heaped up epithelium at the edges, so the devitalized epithelium, all this would stain with rose bengal, which is present at the bed of the ulcer in the metaherpetic ulcer, right? So A is a geographical ulcer and B is a metaherpetic ulcer, where you get a reverse staining pattern. Where you get a reverse staining pattern. All right, that is important. All right. Okay, let's move on. There is an 8 months. Okay. Yes. One more important thing which I always tell is, whenever you read the question, how do you save time? You read it, finish it, come back, see the main points, again read it. No. Whenever you're reading the question, keep on marking the important points that you need to take in consideration. All right. So, like this 8 months old boy examined under general anesthesia using a portable slit lamp and interior segment findings are as shown. What is the likely finding called? I'm not asking you the diagnosis. What is the likely finding called? All right. Now you have to tell me first, from this history and from this picture, for you being an easy thing, I have marked which is the eye under consideration. So this is the eye under consideration. What is the difference between these two? The difference between these two is that if you see, you get to see that there's an enlarged corneal diameter in the marked eye. So what are we dealing with? There is an enlarged corneal diameter in an 8 months old child who's being examined, and these are the slit lamp findings. So what is this? What is it that we are seeing? All right, so I have a mixed response. Some say it's Al's triangle and some say it's Hab's stria. So the answer here is actually, see, this is what I tell you, because the moment you start reading the options, you get confused. You should not have gone to the options itself. You should have straight away called me, ma'am, this is Hab's stria. This is Hab's stria. By that, what do I mean? So basically, what we are dealing with here is, what is the diagnosis? The diagnosis is primary congenital glaucoma. All right. And what you are seeing is basically, you see this on retroillumination. I think this is not visible here. I'll write it above. This is on retroillumination. When you see on retroillumination, what do you get to see? These are called as opaque lines with double contour. So where do you see them? Which slit lamp setting do you see them? You see them in retroillumination. What are these described as? Opaque lines with double contour. And what are the Habs striae? Actually, they are breaks in which layer of the cornea? These are breaks in which layer of the cornea? Tell me, these are breaks in which layer of the cornea? These are the breaks in Descemet's membrane. So these are the breaks in Descemet's membrane. They can be central or they can be peripheral. Mostly peripheral, but they can be central or peripheral. These are opaque lines with double contour seen in retroillumination. Breaks in the Descemet's membrane happens when there is raise in intraocular pressure, there is corneal stretching. It is that time when you get to see these lines, all right, and they are concentric to limbus. These are called as Habs stria. All right. So now my question is, why is it not ophthalmos? Why am I saying it is not ophthalmos? Why did I say this is Habs stria? Because nothing in the question says or talks about increased axial length. What is ophthalmos? Ophthalmos is increased structure of the eye as a whole. The entire globe is enlarged. It is an ox-like eye, but there is nothing, no mention about the axial length of the eye, which is done. All right. So what they are asking is just the anterior segment. And until and unless there is a finding in the question to tell you to talk about the axial length, unless and until there's something to talk about axial length, something to tell you that the globe has enlarged as a whole, you will not call as that ophthalmos. All right, till then we call it as increased corneal diameter. And then two, we come to Habs stria. That is the answer that we have discussed. Third is Arl's triangle. Where do you get to see the Arl's triangle? All right, come on quickly. Where do you get to see the Arl's triangle? Where do you get to see this? Uveitis. Which uveitis? Anterior uveitis. And what is the significance of Isles triangle? What you get to see here is KPs. This is the triangle where the keratic precipitates, they tend to settle down. Yes, they are seen in acute anterior uveitis. And is it Descemet's membrane detachment? Will you call it a Descemet's membrane detachment? No, it is not Descemet's membrane detachment. It is Descemet membrane tears. So it is not detachment, it is Descemet's membrane tears. And where do you get to see the Descemet's membrane detachment? That is a complication which is seen after cataract surgery. This is a complication. Descemet's membrane detachment is a complication seen after the cataract surgery. Hence, I'm telling you the options always mean to confuse you. All right. All right. So let's quickly one more question in regard to the primary congenital glaucoma, the infantile glaucoma. Tell me the classical clinical triad of primary congenital glaucoma. Quickly. I'm just waiting. Quickly. The classical clinical triad of primary congenital glaucoma is epiphora, photophobia, and blepharospasm. All right. So this is the classical clinical triad of primary congenital glaucoma, or what we call it as infantile glaucoma, or now sometimes people say it as developmental glaucoma. All right. Shalini, what do you say? Increased optic, this changes visual. No, no, no. I'm talking about the classical clinical triad. What you're telling me is the findings. What you're telling me are the signs that you get. The classical clinical triad classically describes about the symptoms of primary congenital glaucoma. Absolutely right, Sheikh. It is blepharospasm, it is epiphora, and it is photophobia. Very good. I'm so happy with you people. All right. Okay. Next. What is this? This has multiple answers. So be careful. What is this? Identify. If you can just straight away give me the answer, that would be good. What is this? These are Gonioscopic lenses. Absolutely. Now we all know what kind of gonioscopic lenses. Let's go one by one. Is it a single mirror lens? Let's talk of image A first. Is it a single mirror lens? Yes. All right. C, you said gonio prisms. Very good. B and C, gonio lens and gonio prism. How can gonio lens and gonio prism be the same thing? They are not the same thing. D, there is a four mirror lens, which is the right option for nothing. All right. Gonio prism, yes. Sorry. Now let's come back. No, 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 no. That's wrong. All right. Let's come back to the answer. So the first is single mirror. Option A is a single mirror lens. Number two, it says, is it a gonio lens? Tell me, is it a gonio lens or it is a gonio prism? What is a gonio lens? Gonio lens is the other name for direct gonio lenses, the ones which are used for direct gonioscopy. So they are called as direct gonio lenses, or it is called as a direct gonioscopic lens or gonio lens. Whereas the ones which are used for indirect gonioscopy are called as gonio prism. The ones which are used for indirect gonioscopy are called as gonio prism. So another answer correct here is these are gonio prisms. Yes, Arjun, very good. These are Goldman gonio mirror lenses. But what I mean to ask is 1, 2, 3, 4. What mirror? And the next is it a three mirror lens? Yes. Option B, what I'm talking about. Option B is a three mirror lens. Option A is a single mirror lens. And both of these are gonio prisms. Is it a four mirror lens? No. The four mirror lens would have a extra lens here. We do not take the center one, right? So this is why I was telling you the options always confuse you. So just to brief once more, I will tell you there are direct gonioscopic lenses and there are indirect gonioscopic lenses. When you talk of direct, these are called as gonio lens, and when you talk of indirect, they are called as gonio prism. All right. So the direct lenses have the advantage that they give you an erect image. The patient lies supine, they give you erect image, and bilateral examination simultaneously is possible with direct lenses. Whereas when we talk of indirect lenses, what we are dealing with is a mirror image of opposite angle. That means the images are inverted. That means the images are inverted. All right. I think you're not able to see it down here. That means the images are inverted. These are inverted images, right? So indirect are mirror images of the opposite angle. They give you inverted images. Direct gonio lenses give you erect image, and bilateral is possible simultaneously. But here, simultaneous visualization of both the angles, both the eyes is not possible. All right. So the next important thing is, tell me the angulation of these lenses. Come on. Tell me the angulation of these lenses. So now I tell you, this image A is actually a Goldman single mirror lens. And the option B is a Goldman three mirror lens. So now you have to tell me what is the angle at which this is a single mirror lens. What is the angulation for this mirror? The angulation for this mirror is, please write it down, 62 degrees. And when we talk of this Goldman's three mirror lens, which mirror out of these three is used for gonioscopy is the smallest mirror. So the smallest mirror is used for gonioscopy, and the angulation for this is 59 degrees. All right, this is 59 degrees, right? So both of these are Goldman lenses. These are indirect gonioscopic lenses, which are called as gonioprisms. These are Goldman variety, which is covered under scleral lenses. They have different angulations, and if you can remember the angulation, that is very good, giving a direct edge over the others. And I know you will remember it. All right, so these give you inverted image. These give you inverted mirror images. Both of these lenses give you mirror image of the opposite angle, of opposite angle, right? And that is, hence it is a inverted image. Okay, all right. So tell me the name of the instrument, and you have to tell me its principle quickly. Which is this? The first instrument that I'm talking about here is actually an instrument which is mounted on number one slit lamp. It is mounted, you can see here a slit lamp. It has a prism through which you see something like this. So which instrument is this? Which instrument is this? This is a absolutely right, Kunal. This is a Goldman applanation tonometer. So this comes under the category of applanation tonometer. And what is the principle that it follows? The principle, it works on the principle of Imbert Fick principle. Very good. Imbert Fick law or Imbert Fick principle. And then another applanation tonometer which follows the same principle is this one. And what is the name of the second one, the option B? What is the name of this instrument? This is called as Perkins tonometer. This is called as Perkins tonometer. All right. So this option B is Perkins tonometer. This is Perkins tonometer. The other is, then we come to option C. What is option C? What is this structure? It is, remember this pen. It is like this. What is this? Very good, Arun. Very good. I'm very happy. Very good. This is tono pen. And now the thing is, what is the principle on which it works? Come on. Two more questions regarding to this. One is, tell me the principle of tono pen, and the other is, tell me the name of the other instrument which works on the same principle as tono pen. Come on, quickly. I will write my answer, you write yours. All right, I wrote it first. So this works, tonopen works on the Meckey-Marg type tonometers, and the other instrument which works on a similar principle is ocular response analyzer. Ocular response analyzer. So the other thing which works on the same is ORA, which is called as ocular. Can you see it here? Yes, ocular response analyzer. And this ocular response analyzer measures corneal hysteresis. It measures corneal hysteresis, right? So applanation tonometer, you saw two things. You saw applanation tonometer, which is a Goldman applanation tonometer, and Perkins tonometer, which follow the Imbert-Fick law. Then we saw another instrument, which is this, which is called as a tono pen. It works on Meckey-Marg type tonometry. And the other instrument, which again works on the same, is ORA, which is an ocular response analyzer, and that measures corneal hysteresis. That measures corneal hysteresis. All right. Okay, next. So a patient presents to the clinic with painful diminution of vision, after trauma. On examination, we find lid edema, congestion, edematous cornea with stony hard eye perceived digitally. Following was seen on the slit lamp, the probable diagnosis is. So let's see. There is history of trauma, painful diminution of vision, lid edema, congestion, stony hard eye, and what do you get to see? What do you get to see? Okay, so you say it is phacomorphic glaucoma. A. Finally, Kunal, after attempting A, you said it's dislocation of the lens, right? So, is it going to be D? No, it's not D. The correct answer here is phacotopic glaucoma. No. I'm happy only I got it right. So listen, it's not phacomorphic and it's not phacoantigenic. Let's quickly revise what are the differences, what I'm talking about. So when we talk of phacomorphic, see, I always tell you, do not try to just memorize what's happening. Science is beautiful. Science tells you everything in its name. Phaco means lens, morph means shape. So all the initial answers that I got, A is wrong because phaco, lens, shape. So phacomorphic itself says that I am because of the shape of the lens. So phacomorphic glaucoma is one when you have the morphology, the form, the shape of the lens has changed, when the lens becomes intumescent, but it's in its normal anatomical position at the patella fossa. But what you get to see in the picture is, now pay attention, you see here is the lens. The iris is behind. So that means the lens has come actually in the anterior segment. The lens has moved from its anatomical position. Also, a similar picture to tell you about this is this. Remember, this is behind the iris, but it has gone down. So that means the lens has moved from its normal anatomical position. And once the lens has moved from its normal anatomical position, and the question is talking about glaucoma, that means it is phacotopic. Phaco is lens, topic means topology, the lens, the position, the geography. So it is the position of the lens which is giving you glaucoma, and that is called as phacotopic glaucoma. So it is not phacomorphic, it is phacotopic glaucoma. Let's see, now it is not phacomorphic. We're clear with it. It is not juvenile open angle glaucoma. Very clear with it. There is no clinical scenario which is corresponding to JOAG. Then the next is phacoantigenic glaucoma. I did get some answers saying uh, that it is D. It is not D. It is phacoantigenic glaucoma because lens induced antigen. When you talk of phacoantigenic glaucoma, remember there will always be the presence of, the question will talk, the image will talk about KPs. Number one, there will be keratic precipitates which are present, and always in phacoantigenic, phaco means less, it is antigenic. So lens, when it becomes antigenic, there will be a time for sensitization. There will be a time when there will be a prior exposure to the lens antigens. Only then they become, because lens has an immune privilege status, so then they become antigenic. So it is not even phaco antigenic. So it is phacotopic glaucoma, right? So now you have to tell me what are the most common causes of ectopia lentis, because what we get here is actually ectopia lentis. So what are the most common causes of ectopia lentis? Well, I remember them as, please tell H&M the wardrobe ensemble is super. This is the mnemonic by which I remember it. All right, so tell me. All right. Just I'll quickly write down to save time because I think we're running short of time. So I remember as that. Please tell all the people who love shopping will like this. So P means pecs. These are the causes of ectopia lentis. Right? So P is pecs, T is trauma, H is homocystinuria, M has gone here, M is Marfan syndrome, and microspherophakia. W is Weil-Marchesani syndrome. E is Ehlers-Danlos syndrome. And S is, any guesses? S is, you can see this, sulfite oxidase deficiency. So this is how I remember it as. Please tell H&M wardrobe ensemble is super. These are the causes of ectopia lentis. These are the causes of ectopia lentis, right? So moving on to the next. Is it for NEET UG, ma'am? All right. I think everybody has gone through this. I think this will be a very higher level for NEET UG, and we do not teach ophthalmology in UG. It's not for the NEET UG. They study physics, chemistry, biology. So I think some confusion here. Anyways, coming back to this. So now what are the images showing? So these are basically, I'll just form a short history about the images. Once the patient gets operated for cataract, the person comes back to you with certain symptoms. There would be a painless diminution of vision. There will be monoocular. These are all different images. This is A, this is B, and this is C. So first I'm talking about A and C. So they come to you with a painless diminution of vision with monoocular diplopia, right? Painless diminution of vision after cataract surgery with monocular diplopia. Yes, very good. Which is sunset sign? This or this? This is a, anyone? It is very good. It is a sunrise syndrome because it appears like a rising sun. And this one, it appears like a sunset. You get a very beautiful hue from the retina, and it, yes, it is not B, Kunal, it is C. So this is a sunset syndrome. This is a sunset syndrome. And when I talk of option B, basically this patient has monocular diplopia, which is variable, which moves with the movement of the head of the patient. So what is this? It moves with the movement of the head of the patient. So what is it? Come on, tell me. Marfans, no, this is not the natural crystalline lens. And see, you can see it here. You can see the haptics and the optics. So it is not the crystalline lens. It is not Marfan syndrome. This is called as windshield wiper syndrome. This is called as windshield wiper syndrome. Here the patient has diplopia, has monocular diplopia. When the patient moves the head, the images also move because there is the lens which is not fitted, and the lens also keeps moving with the movement of the head. Very good, rhythmic dog. It is windshield wiper syndrome or windshield wiper phenomena, which is C. All right. So next, coming quickly. So the image A. Let's talk of image A first. This image I'm talking of, this is a young patient who had a blunt trauma, history of trauma, presents to you with this cataract. What is the name of the cataract? Quickly, I have to cover more images. We are we're falling short of time. This is called as rosette cataract. This is called as rosette cataract. Why is it called as rosette cataract? Because if you try to follow this, it becomes like the petals of a flower seen after blunt trauma. Coming to the next image, image B. This is a patient who works in the glass industry and comes to you with these discoid posterior opacities with true exfoliation. What kind of cataract is this? Option B, image B. What kind of cataract is this? Come on, tell me. This is radiation cataract. What are the types of radiation cataract that you have? It is because of UV rays. It is because of ionizing radiation. And which type is because of this? Option B. It is infrared or intense heat. And this type of cataract is called as, what is this cataract called? Very good. This is called as glass blowers cataract. This is called as glass blowers cataract. Last but not the least, we have an electrician who works with you, and he presents to you with this kind of vacuoles. If you see the image here, you can see these, like these are the flowing currents. So what kind of an cataract is this? This is called as, so as I tell you, there will always be a hint in the question. So here the hint is that he's an electrician. So electrician is bound to go under a lightning injury or an electric shock. So what is this called? This is called as electric cataract. This is called as electric cataract. All right. Okay, moving to the next. Now, quickly tell me the types of lenses that you see on the screen. Option first is this, A, B, and C. Tell me which kind of lens is seen here. What kind of a lens is this? Quickly seeing the points, if you see, this is the optic, this is the haptic. They seem to be in the image of the same material. So it means it is a single piece monofocal posterior chamber IOL. Right? This is the complete name that you should know. It is a single piece. It is monofocal. Why do I see the word monofocal? If you see the optic, see, there is nothing which is there on the optic. Whereas if you compare it with a similar picture here, in this B, you compare the optic. You see all these rings, you see these multiple rings here. So if you compare these two, now compare this and this. So this, the optic is absolutely plain, nothing is visible. But if you see here, there are rings on this optic. So what is the difference? The first one is a single piece monofocal posterior chamber IOL. Right? Whereas the option B is a single piece multifocal. It is called as multifocal posterior chamber IOL, which has multiple foci to focus for near as well as distance. And what are the two types of multifocal IOLs that you know of? The two types of multifocal IOLs that we know of are diffractive IOLs and refractive IOLs. And then if we talk of the third category, what is the difference here? The difference here is the hinged haptics. You see these hinged haptics? So what kind of an IOL is this? No, this is not an iris claw lens. This is a accommodative IOL. This is called as accommodative IOL. So these hinged haptics basically help in the movement of the lens when you try to see the near or the intermediate. And this is good for distance, near as well as intermediate. So these are called as accommodative IOLs. So accommodative IOLs have these hinged optics which tend to make the lens move when there is when you attempt accommodation. All right. So next, coming to this, a female presents to the OPD 3 years after cataract surgery and complains of painless progressive diminution of vision. Slit lamp examination shows the below image and the foveal contour is maintained on OCT. What is the diagnosis? All right, I'll just answer you why B is not toric, right? All right, so once you talk of toric lenses, I'll tell you. The toric lenses basically, one will not have these, if you're talking of simple toric lenses, they will have the optic which is clear. And if I make these changes to this lens, then this lens becomes toric. Even with multifocal, you can have toric, but the toric lenses will have some dots like this, which is actually the axis, which mentions the axis where you have the difference or the where you have the cylindrical power. Right, Kunal? So that makes it a toric lens. If they are not, these dots are not present, these dots are not visible, then it is not a toric lens. Because toric lenses are basically for astigmatism, so they need to have an axis which is higher in the power, all right, which has a different power. So that axis will always be shown in toric lenses, all right. I hope I could answer that. All right. So now when we come to this, yes, the answer I have already got. This is very simple. This is called as after cataract posterior capsular opacification, and this is the most common cause of late post-operative diminution of vision, which is painless. All right. And now you have to tell me, why is it not cystoid macular edema? Why the answer is not A? The answer is not A. Why? Because it says maintained on the foveal contour is maintained on OCT. That means the fovea is absolutely right. It is not IOL drop because you can see the holes here in the optic. So IOL is right there, and there's no retinal detachment because the foveal contour is maintained. There's nothing which is being talked about the fundus. So it is the posterior capsular opacification, which is the most common cause of late postoperative painless diminution of vision. All right, and it is also called as secondary cataract or after cataract. And what are the uh, other presentations or the different presentations that you can have with PCO with secondary cataract is Elchnick pearls, where you will find these globules, enlarged globules, or it can be a Soimeres ring. When we talk of a Soimeres ring, it is like this thickening which is happening at the edges. So both these Elchnick pearls and Soimeres ring are actually the variants of posterior capsular opacification. But remember, Elchnick pearls, once it goes into the visual axis, will cause diminution of vision. But if the Soimeres ring with a central clear visual axis is there, there will be no diminution of vision. And what is the treatment of posterior capsular opacification? Very good. It is YAG capsulotomy. It is, what is the treatment, which laser is used for capsulotomy? It is neodymium YAG capsulotomy, which is shown here, right? If you see carefully, they have cleared the central area to you do not go and destroy the entire posterior capsule, absolutely right. It is a neodymium YAG laser which is used to do a capsulotomy. Perfect. So this is how a cystoid macular edema would look. If you see the picture, the foveal contour is lost, which gives you a classical petaloid appearance on FA, and OCT would have a increased macular thickness with cystoid spaces which are present in the intraretinal layers. So that would be a cystoid macular edema. Last but not the least, come on, identify this picture. This picture, if you see, this is a very clear cut picture. The answer is band shaped keratopathy. So here what you need to tell me is, one, which layer do you get the deposits, and what deposits do you get? So what is the layer that is involved here is the Bowman's membrane. So which layer is involved? It is the Bowman's layer. And what is deposited here? No, Kunal, it's not Descemet's membrane. It is Bowman's membrane. Calcium. What calcium salts are deposited here? Come on, next. Which calcium salts are deposited here? Answer me. I'll also write my answer. It is calcium phosphate or calcium hydroxyapatite. This is the form of calcium which is deposited. And why do you get the holes here? Calcium phosphate and or calcium hydroxyapatite is one which is most commonly seen, which is deposited in the Bowman's membrane, and it has holes in the center. If you see these holes, why are these holes present? These holes are present for the nerves. This is because of the nerves, right? This is because of the nerves, corneal nerves. So quickly, you know what the causes are. You all know the most important I would like to point out is chronic anterior uveitis, especially in JIA or juvenile rheumatoid arthritis, glaucoma, and phthisis bulbi. Rest you can remember. You have to memorize the list. Important thing which I need to point out here is what is the treatment? EDTA. But remember the concentration. 1.5 to 3% EDTA chelation is what is done. You can do a lamellar keratoplasty, PTK, excimer laser, and diamond blur can be used. All right, so quickly, this would be the last slide for the day. All right, so identify. What do you get to see here? This is very, very easy. Just to clear it, these are the, you see this? What is this? This image is, these are the Coipes nodules. These are perfect. How do you remember it? Coipes is say P. It is at the pupillary margin. So these are the Coipes nodules. And when we talk of image B, these are called as at the pupillary margins. And this is at the surface of the iris. This arises from anterior iris stroma, and this is called as, it has stroma, it has S, it has a surface. Absolutely, you call it as Busaka's nodules. And what are the nodules called which you get in the angle? What are those nodules called which you get in the angle? Come on, what are those nodules called? Those are called as Berlin nodules. Those are the Berlin nodules which you get at the angle. Okay, so now, as for now, okay, quickly wrapping up. So you have to tell me, just see the images and tell me the fundus findings in the myopes. Let's quickly revise. Okay, so let's start from this image first. What do you get here? What is this? These are lacquer cracks. And what are these lacquer cracks? Where do you get to see them? These are seen in myopic fundus. So these are the cracks which have happened in the choroid and the RPE. All right, coming to this image, what is this? These are the Foster Fuchs spots. These are the Foster Fuchs spots. What is this? This is a retinal hole. What is this? These are the crisscross lines in white color that you see. What is this? These are lattice degeneration. This is lattice degeneration. What is this which is seen at the macula? This is myopic CNVM, which is right there at the macula. Another structure which is seen at the macula. What is this? This is macular hole. And here to show you, there's a horseshoe-shaped tear with detachment. You see these folds? These are the detachment. So these are the findings of macular myopic fundus seen in pathological myopia, and you call it as pathological myopia when it is more than or equal to -6 diopters. All right, so that is when you call it as myopic fundus or a pathological myopia. So we end up with this again in another picture of RD, what you see here. So once you see this on this image, you see a large tear here, and there is retinal detachment, which when seen on ultrasound on B scan gives you a hyperechogenicity, which is seen in the vitreous cavity, which is corresponding in the A scan to the spikes of the sclera, and it is seen in a convex shape, and this is the B scan of rhigmatogenous RD. This is the B scan of rhigmatogenous RD. So rhigmatogenous RD would have convex right? It would be convex. Number 2 would be mobile. It will have after movements with the eye, which would be seen in the B scan. Whereas when you talk of a similar picture in the other one, what you see here is, see, there is a tabletop kind of an RD. There is something which is pulling it up, and that is called as a tractional RD. And what is the B scan finding that you see? So this is the detachment which is there, and here is the point of vitreoretinal traction. So there is this point which gives you a tabletop appearance. And when you talk of a tabletop appearance, what you get is the RD has concave contour. Sorry, it has a concave contour. It has a concave contour, reduced mobility, and there will be no after movements. And there will be no after movements. Why? Because there is something which is, kind of binding it up on the top. Absolutely. So this is tractional RD, and this is a rhegmatogenous RD. So let's finish. This is the last slide. Identify this test. Which test is this? Anyone? This is called as the Bruckner's test. Now, what you have to see carefully. There is a direct ophthalmoscope which is visualizing both the eyes, right? This is not leukocoria. Just remember, this is a direct ophthalmoscope which is shown, and once you see the red reflex from both the eyes. So remember, in Bruckner's test, this is basically done it's a very initial screening test which is done to detect the visual disorders. So whenever the direct ophthalmoscope, there is foveation of this red reflex. That means when the eyes are in normal alignment, and when the red reflex is coming from the fovea, the foveal reflex would be dim. The foveal reflex would be dim. Whereas the extrafoveal reflex, or when there are visual disorders because of refractive errors, it would be bright. So this is called as Bruckner's test. So here, since we are talking of squint, so I would take this off. So the extrafoveal reflex is bright. So which is the abnormal eye here that we are talking of? Remember, foveation of the direct ophthalmoscope reflex will make it dim, whereas the extrafoveal will make it more bright. So this is the eye which is under query, which needs a diagnosis, which needs to be worked upon. So this is called as Bruckner's test, which is done at initial screening. All right. So that is it. I hope we could cover and you could revise a lot of images. So as I always say, just look at the image, try to focus on what is the major point, because once you finish the question will give you a hint, and the image would be a classical picture of a characteristic finding. All right. So with that, I'm signing off. I wish you all the best. Just believe in yourself. Just believe that what you know, what you have learned, what you have been taught is the best, and you remember it. Do not panic. Have a good sleep. Rest, because you need a fresh mind to apply. Right? I wish you all the very best. And if you want me to cover anything particular before your exams, I know there is a shortage of time. You have a lot of things to revise. But if still you want me to cover up something in a concise manner, in a quick revision manner, before my 25th or 27th, which is on the platform, you can let me know on my Telegram group. The link is right here, and I will be very happy to help you out. Any other queries, please, you can reach me out. I will be there to help you out with any query related to the exam, related to ophthalmology. And wish you all the best. Stay calm, stay cool. Thank you. Have a good day.